Welcome back. This is lecture part 2 of complications of diabetes. In this PowerPoint, I will be discussing the chronic complications in diabetes mellitus. There are many complications. However, the most common are listed as peripheral neuropathy, which are pathological changes to the nerves; nephropathy, which are pathological changes in the kidneys; retinopathy, which are, again, pathological changes in the retina; and vascular changes. Specifically, we're looking at arteries, and arterial are the most susceptible to accelerated arteriosclerotic and arteriosclerotic changes versus those patients without diabetes. Diabetic neuropathy is nerve damage that occurs due to the metabolic derangements associated with diabetes mellitus. These are, again, pathological changes in the nerves of the periphery. Most common among the diabetics who have poor glucose control and those who are smokers. Neuropathy can affect the motor, sensory, and autonomic nerves. Typically, onset is gradual, so these patients are unaware that this complication is ensuing until it is way too late and the disease has progressed quite significantly. Smoking accelerates risk as well as poor glucose control. Here's where your education on the importance of maintaining good control of blood sugars starts, as well as educating on patients' smoking cessation. And we have many programs here in Wyoming that help those patients with support. They'll even help them with meds, maybe some patches to help in that smoking cessation. So we have a great program here in Wyoming. Personally, I think it is important to know that neuropathy can precede, it can accompany, or it can follow the diagnosis of diabetes. Also, both types, type 1 and type 2, are affected by this complication. Motor neuropathy, which is the motor nerves are affected, causing weakness and atrophy. It also, joint support can be diminished. Bone structure can even be affected, causing deformities in the ankles and the feet of these patients. Skin and soft tissue are at risk for ulceration. Again, I think I've talked about this in the previous lecture, but skin is definitely a high-risk issue when subjected to friction and pressure for these patients. Then we're going to look at the sensory neuropathy, and the sensory nerves are affected, causing abnormal sensations such as prickling, burning, tingling, and itching, or even needle-like pain. This is typically the most common type of neuropathy in patients with diabetes and can lead to loss of protective sensation in lower extremities and sometimes even in the hands. As nurses, we identify these symptoms as paresthesias. For this reason, foot injury can occur and have without having any pain for these patients, and the patient is unaware that the injury has occurred. Hence the importance of daily foot checks and routine podiatry exams. This is one of the causes of why patients become amputees. They get this tiny little cut on their foot, have no idea it happened. They didn't check their foot for a week, and it has ulcerated, and then we've got stage 3, stage 4 ulcer. So it's very important for these patients to check their feet. Autonomic neuropathy, which is the autonomic nerves affected, it can affect the stomach, the bladder, cardiovascular system, etc. Autonomic neuropathy can affect pretty much nearly all body systems and lead to unawareness of bowel incontinence, diarrhea, urinary retention, urinary incontinence, delayed gastric emptying, which is also called gastroparesis, and this is a complication of this, can produce anorexia, vomiting, cause GERD-like symptoms, and the feeling of being full, which can actually trigger some hypoglycemia by delaying food absorption. Urinary retention can cause frequent UTIs by bacteria building up. Urinary incontinence can occur in these patients, and erectile dysfunction is identified in 50% of men with diabetes. In the cardiovascular side, orthostatic hypotension can occur, as well as painless angina, which delays prompt treatment of the heart. So these patients are having chest pain and don't even know it. Pain is the leading symptom to motor and sensory nerve changes. Skeletal muscles, you may on your assessment find that they are smaller. The feet will be swollen and they become insensitive to temperature or tactile stimuli. And the digestive, urinary, or sexual dysfunctions, the patient will often say are dysfunctional. And so that is part of your assessment. When the patient is arising or standing up, they may have some dizziness, so that will also be on your assessment. Development of these complications can happen 10 or more years after onset of diabetes mellitus. However, personally, I feel that sometimes you can have it before, or it can actually accompany the diagnosis. Medical management for these patients. So we're going to look at diet, exercise, and medication to control blood glucose. It is very important for these patients to have good glucose control. As far as pain management, we're going to look at some non-narcotic medications for these patients, and then we're going to look at some tricyclic antidepressants such as imipramine, which is trophanol, and then we can look at some anticonvulsants such as pregabalin, which is known as Lyrica, gabapentin, which is known as Neurontin, and carbamazepine, known as Tegretol. Transcutaneous electric nerve stimulator can help with pain relief for non-pharmaceutical interventions. We could use elastic compression hose, increased dietary sodium intake, and Florinef and Proamidine can help decrease orthostatic hypotension. Again, we talked ACE inhibitors can help with patients to also decrease some of these problems in the vasculature, and I'll go more into the ACE inhibitors further along in the retinopathy and the nephropathy, but I'm going to bring that up now. So ACE inhibitors will be used to help with some of these vascular changes, but you'll see more of them being used for the retinopathy and the nephropathy. As far as nursing management, it's important to educate on diabetes management and the potential complications. As you can see, these can be really severe and debilitating for that patient. Diabetic education classes for these patients, and foot care cannot go. I mean, our next slide is talking about foot care, but this is extremely important. I have seen many patients take their limbs off because of poor glucose control, and they ended up having to amputate a foot. Education on rising slowly to avoid orthostatic hypotension. So it is important for us to educate in that realm for these patients. As I previously mentioned, we're going to go into foot care, and as you can see here, I mean, this patient in this picture obviously stepped on something, had no idea, and now look what we've got. We want to inspect the feet daily. We want to wash feet daily for these diabetics, and no hot water. Again, I talked about that sensory neuropathy, so sometimes they can't feel whether it's too hot. So they should always have somebody else check the water and make sure that it's not too hot. I have actually been working in a burn unit. I have seen patients have to take their limbs off because they scalded their feet and just had no idea. So we want to keep toes short and cut straight across. We don't want to cut rounding on the toes because those can cause ingrown toenails and those can cause ulcerations. We want to use a moisturizer daily for these patients. No razors, abrasive, or commercial products to remove any of the corns or calluses. And that's something you'll be looking for on these patients. How are their corns and calluses? Use lamb's wool for toes that overlap because, again, that friction can cause an ulceration. Well-fitted shoes. No rubber and no plastic. And the reason for this is because patients sweat. And with that sweat, the skin becomes fragile. And again, we've got friction and pressure, and then we can develop a sore. Never go barefoot. So this is one of these things that we tell these patients is never go barefoot because, again, they can step on something, and if they've lost that sensory, they have no idea they've done it. And even 24 hours, if they check their foot that morning, step on something later that morning, and by the next morning we have a full infection. Visit a podiatrist regularly. And most podiatrists have anywhere from like 3 to 6 visits, so that will be very important for these patients. Wash, dry, and cover injuries and seek medical attention immediately. So if your patient comes in and says, oh, by the way, last week, no. Patients need to be informed that if they notice something immediately, they need to contact their physician. Again, this is extremely important. They contact their physician about any blister, abrasion, or foot injury immediately because things can progress very quickly with these patients. Diabetic nephropathy is a gradual decrease in renal function, a microvascular complication associated with damage to the small vessels that supply the glomeruli of the kidney. Good blood glucose control is critical to the prevention and delay of diabetic nephropathy. Hypertension will significantly accelerate the progression of this complication if the patient has diabetes, eventually leading to protein in the urine. Patients with type 1 are often seen with this complication, but type 2 can develop it also. So both types of diabetics are affected. There are 5 stages to diabetic nephropathy, and you can see those on table 51.5 on page 880. Poor glucose control, again, is a contributing factor. Hypertension can accelerate nephropathy, and smoking also can accelerate this disease process. Nephropathy assessment findings. No obvious signs or symptoms in the early stages. Eventual gradual development of signs and symptoms include elevated blood pressure, lethargy and weakness. Patient will have proteinuria that can be identified on clinical assessment, edema in the extremities, and the patient may have elevated BUN and creatinine, and a decreased renal creatinine clearance. So how do we manage these patients? First and foremost is control blood glucose. Again, we talked about we like those patients between 70 to 110. So if a patient has hypertension, we want our goal 130 or 85 millimeters of mercury at or below. However, if a patient has proteinuria already and is spilling that protein into their urine, we want to see a goal of 125 over 75 millimeters of mercury. Again, that is in patients with proteinuria. What are we going to use with that? We are going to use an ACE inhibitor or an angiotensin II receptor blocker, which is also known as an ARB. So we are going to put these patients on an ACE inhibitor. If they can't tolerate it due to a cough, then we'll put them on an ARB to delay this progression. Some nephrologists, and I speak about this in regarding experience, some nephrologists will actually put their diabetic patients on an ACE inhibitor before hypertension starts. And this is kind of one of those preventative factors. So they'll put them on a low dose ACE inhibitor, give them 5 milligrams of lisinopril, even if they don't have high blood pressure, just to kind of bring that down so we can kind of prevent it and things look well on them. Again, we're going to stop smoking, so we're going to get these people to smoking cessation classes and get them the help that they need. And we are also going to reduce their dietary protein. If they're spilling protein in the urine, they don't need any more to be spilling in the urine, so that causes more damage. So let's take a look at diabetic retinopathy. This can be classified in two ways. First, we're going to look at non-proliferative nephropathy. This is the most common form and is considered much more milder, which is a partial occlusion of the small vessels in the retina, which causes the development of microaneurysms in the capillary walls. These walls are so weak that the capillary fluid leaks out. And what happens when fluid leaks out? Talked about this over and over. We develop edema or swelling of the retina, which eventually can cause exudates or intraretinal hemorrhages. And in this photo, we can see the exudates and the microaneurysms here. So I specifically put one for normal and one with the diabetic retinopathy. So this gives you a good idea. This eye here of the diabetic is just very diseased. The proliferative is the most severe and involves the retina and vitreous. When the capillaries of the retina become occluded, the body compensates by forming new vessels to supply the retina with blood known as neovascularization. If the macula is involved, then vision is lost. And here, again, why I posted this picture is you have the neovascularization, and you see those extra, if you just look real closely, you can see those extra vessels trying to supply the eye. So it is very, very important. These are not very good vessels. They're just compensating for what is occluded. So diabetic retinopathy assessment. We're going to look at patients going to have visual changes that may not occur for some time. But when they do occur, they're going to see things floating around in their eyesight. They'll have some blurred vision, maybe some visionless spots or little spots that they can't completely see through. They'll have some diminished visual acuity. So on ophthalmic exam, they are going to notice swelling or that edema that we talked about from those leaky capillaries close to the macula. And again, when I said if they're close to the macula, then vision is lost. Retinal angiography suggests changes in the retinal blood vessels. As far as medical management and nursing care, these patients really need annual eye exams, which are really important. I talked earlier about the ACE inhibitor for the neuropathy and the nephropathy. Here again, it is important to have this ACE inhibitor. So we don't have those high pressure. If you have a lot of high pressure in an occluded vessel, of course that's going to make things even more leakier, or you're going to have more swelling. So that ACE inhibitor kind of keeps everything at a low, management. The best way I like to explain it to my patients is if I go out, if you think of pressure, or you think of blood pressure, think of that pressure in the eyes, think of that pressure going to the kidneys. If you go outside and you turn on a garden hose, just think about it. Grab that garden hose and turn on the spigot just slightly. You're watering your beautiful flowers there. That you turn on that spigot nice and slow, you're going to have a nice slow flow rate. But your plants might not get enough water to make them, to help them grow. So that's not necessarily a good thing. So now you turn on the spigot to a nice, let's put it in medium, a couple of turns there, and you have this nice flow. And that doesn't, when you're pouring the water on your flowers, it doesn't damage your flowers. It waters them nicely. They're getting adequate water supply. Now, take that spigot, put it all the way on high, and grab your finger on that hose, and that pressure there, see what you're going to do to those flowers. You are going to ruin them. So that's how you can see. If you have that high pressure, it ruins the vasculature of the eyes. It ruins the vasculature of the kidneys. So high pressure is never good. So again, that ACE inhibitor helps. Laser photocoagulation to seal those hemorrhages can also be done. And a vitrectomy, and Vitrase is used for the closure of leaky vessels. So again, in our nursing care, education. Very good education on good glucose control. Get them to a diabetic educator and regular eye exams. Diabetes is absolutely horrible. It is one of the most monstrous diseases out there. It destroys everything in the body. And not only that, it destroys families. And this is all preventative. We can prevent a lot of this through our education. And that's why we're here. That's why we are nurses. We want to educate them so they're not coming back to the hospital. So we want to talk to them about that good glucose control so they don't have these complications. They will have complications down the line. But our goal is to prevent all of that. And we want these patients with regular eye exams. Get those eyes checked annually. And if they need it more, then get them more frequently. Well, thanks for listening. That's all your lectures. I appreciate all your time that you students have given me. Thank you.